Hello, everyone. I'm Nick Hart. I'm Professor of Respiratory and Critical Care Medicine and Clinical Director of Respiratory Sleep and Critical Care at Guy's and St Thomas's Hospital in London. What I'm going to talk to you about is our approach to COVID over the last year to 18 months, and indeed give you some direction of the approaches that we've used in our institution. So 469 days ago, we admitted our first patient with COVID, and that was as a high consequence infectious disease, as it was then termed by the WHO. Some 462 days ago, we admitted our first patient again to the high consequence infectious disease, but this was as part of the severe respiratory failure program we run at our hospital. And so we've been in this process of managing patients with COVID for some substantial time, similar to others. Now, during our second wave of COVID, we saw 1,817 patients, and the overall mortality of the hospital admissions was only 12%. 544 patients were actually admitted to critical care, where we saw a mortality of 24% to ICU discharge. So when we reflect on what we have done in terms of our management of patients with acute COVID, coordination of care has been essential. And indeed, when you look through the milestones of our 18 months within COVID, the number of changes we made in the institution were significant. But a major driver of all of this was a greater understanding of the disease and a greater understanding of the disease and effective treatments to treat the disease. And we took a view of following the science. We also embedded data-driven clinical care into our delivery model. And that required us to bring together a significant number of specialities with comprehensive integration across acute medicine, anesthesia, pediatric anesthesia, infectious diseases, respiratory medicine, and critical care. So as you see, we had a COVID delivery model where this was embedded in our hospital services, but also extended into community care. And we had evidence-based clinical care delivery. We had data-driven clinical care. But we also focus on staff health and well-being as a primary importance. And this interacted obviously with the national agenda through Public Health England, with a research delivery group through the NIHR. But also we provided a significant support to our surrounding hospitals in terms of taking patients from them when they were at capacity to ensure that they had enough capacity to look after the patients they've got. And we did this across South East London, across London, and even beyond. During the first wave, we deployed a significant number of doctors and nurses into the critical care, which was modified during the second wave as we had different models for delivery of that care. And in fact, in the first wave, we were planned to go to 189 critical care beds, and in the second wave to 220 critical care beds, with deployment of 70 junior and senior doctors and 368 nurses. We moved from a baseline of 76 emergency critical care beds up to 220 emergency critical care beds, which meant we had to expand and commission 6 critical care units in order to incorporate this into the structure of delivery. As I said, we use data-driven clinical care, and we use monitoring and modeling as a central part of how we were going to deliver that care. We monitored all those patients having asymptomatic testing. A number of patients who come through to our service, whether it's elective surgery or dialysis, or patients having upper or lower endoscopies were all screened prior to admission. And so we monitored these, and you see here that we, at the beginning, towards the end of September, we were sitting at a level of about 0.3% of all those symptomatic swabs being positive. That's 3 in 1,000 patients had a positive swab, although they had no symptoms. By the 19th of December, you see that that's 5 in every 100. And remember, these are asymptomatic patients. They do not have symptoms, and so they are significantly important in terms of spread of the disease. We saw the same lighting of the COVID fuse for the 5-day rolling average for admissions to hospital. And indeed, when you hit a 5-day rolling average of more than 5 per day for our institution, we knew we were moving into a situation where we would soon be hitting the exponential part of growth, and with patients coming through the front door at a very rapid rate. When you look at wave 1 and wave 2, and this is in the ICU, you see the significant difference between wave 2 compared to wave 1. But again, you see the lighting of the fuse. From the beginning of September, we see a rise in the number of COVID cases within the ICU. Again, knowing the bed occupancy over that 5-day or rolling average of 5-day allow us to understand the length of time we would need before the exponential will occur. And this is all important for our planning for the third wave. In the first wave, we peaked at 153 patients, and in the second wave, we peaked at 204 patients within the critical care. As I said, following the science is key, and really this is a virally triggered inflammatory response with the onset of the infection, and following the onset of infection, whether it be symptoms of loss of taste and smell, whether it be fever, muscle ache, muscle pain, fatigue, then it's the 7 to 10 days after the onset of symptoms that we saw the significant inflammatory response. We know this is a multi-system inflammatory disease. We know this is a disease that leads to significant acute lung injury. So when we think about the actual pathophysiological mechanisms, what we see is the SARS-CoV-2 virus binds to the ACE2 receptor. It then gets internalized, and that leads unopposed angiotensin II. And that results in the inflammatory response, which you see through the brain, the heart, the liver, kidneys, arteries, veins, intestines, and pulmonary vessels. So this is a systemic inflammatory response syndrome. And what we saw in patients coming through the front door, that they had modest hypoxia at first. And indeed, when they came in, they had given oxygen, which would correct their hypoxia, but they still had large tidal volumes. There was definitely a pontine pneumatatic center stimulation, which stimulates tidal volume relatively or relative to the respiratory rate, which is determined by the dorsal respiratory group in the medulla oblongata. So this differential in output and neural respiratory drive leads to a high tidal volume. That high tidal volume leads to large transpulmonary pressures and worsening of acute lung injury. These are soggy, these are inflamed lungs, and the shearing forces lead to further damage, worsening of pulmonary edema, a restrictive ventilatory defect, a rising elastic load, which then increases the respiratory rate. So you may see tachypnea as an advanced sign of the disease. Not only that, this was middle-aged obese patients, and we know when middle-aged obese patients will lie flat, then you'll see the functional residual volume, particularly, as I said, in the flat position, the supine posture, and it'll be below the closing capacity. That means there'll be small airway closing and opening during expiration and inspiration, and this leads to further inflammation within the airways through microtrauma. And again, that's exacerbated by the increase in transpulmonary pressure in those who've got upper airways obstruction, obstructive sleep apnea that's untreated. And obviously, so we saw the secondary pulmonary vasoconstriction and pulmonary perfusion effects, which led to what we saw of patients with thrombus in their pulmonary vessels, or at least poor flow. So in terms of evidence-based clinical care, we had descriptive tools to ensure that we were delivering the same level of care to each patient. These were guidelines we had in our own hospital to ensure that we're identifying patients and identifying patients who are going to benefit from the treatments we had available in the second wave. Indeed, we used the big five. We focused on fluid balance, oxygen therapy, antivirals, anti-inflammatories, and obviously anticoagulation. And those will have seen that the recent Lancet paper, which looked at using anticoagulation as a thromboprophylaxis in either treatment dose or prophylactic dose, is there was no difference. And indeed, in the treatment dose, there was increased bleeding. And so it is going to be that we suggest people have prophylactic anticoagulation unless you see a patient who has an identifiable clot. In terms of follow-up, we discharge people in the second wave, and we discharged a significant number of patients in the second wave who were not admitted into hospital. However, we were concerned that at 7 to 10 days, these patients would then deteriorate. So we had a telephone follow-up triage service, which would go through and highlight whether the patients have remained stable, whether they remain improving, or whether they were deteriorating. And obviously, if they were deteriorating, we would bring them back to the hospital after discharge from the ED. And as you see here, 5,000 telephone calls were made, 53 patients came back to the hospital, and of those, just over half were admitted. Now, importantly, only 4 of those patients went to the intensive care unit. So over the 5,000 patients that we discharged but put onto telephone follow-up, we managed to maintain them out of hospital, and they had a trajectory of recovery. In terms of the patients that came in through the front door, we had clear guidance on how to manage patients in terms of the hypoxic respiratory failure. There is no doubt, as I've highlighted, that the work of breathing, the tidal volume, we were concerned about, as this leads to the patient-induced lung injury, the self-induced lung injury. And so we were keen to monitor patients, and they were reviewed on a twice-daily basis by the critical care response team. And if they had rising oxygen requirements with a falling saturations, then the patient would then be intubated and ventilated and transferred to the intensive care unit. We also use proning, although there's no evidence to suggest this has an improvement in clinical outcome. It improves physiological status. And so we would need further research to say that proning has a substantial advantage in patients with the lung injury that we see with COVID-19. In addition, we had the mobile emergency rapid intubation team, which supported the critical care response team, ensuring that patients were intubated and ventilated in a timely fashion and then transferred to the intensive care unit. Whilst on the intensive care unit, we had protocols to understand whether this was more of a perfusion issue, a ventilation issue, or an oxygenation issue. And so we would divide the patients up depending on what their pulmonary compliance was. And this allowed us then to ensure that we were giving the right treatment to the right patients. In terms of the second wave, we peaked at 204 patients, and that was 170 COVID patients. And again, it's highlighting the fact of where we were lighting the fuse, and you see this rise in the COVID numbers. But it's at that point you need to be in preparation for the exponential that will be coming within about a month. So when we look at the level 3 and level 2 patients, and what we're dividing here is those who received invasive ventilation to those who received non-invasive respiratory support. I've been very clear not to label this because some of the non-invasive respiratory support and a significant proportion of that we use with actually low flow oxygen. So if you look across this table, what you see is there was a significant survival in those who received level 2 care, with a shorter length of stay. Now, importantly, for the level 3 patients, these patients were intubated and ventilated, and 7 out of 10 of those patients survived. And we've just had the data from wave 1 and wave 2. And again, when we combine the data, we saw that 7 out of 10 of our patients who went to the intensive care unit survived. In the second wave, we saw patients who went to the intensive care had more comorbidities. And that gives us hope that we are understanding this disease further. When we look at the respiratory support, the non-invasive respiratory support, as you see, we use low flow oxygen. We use high flow oxygen. We use high flow oxygen and IV, non-invasive ventilation and oxygen. But you see, this is not ubiquitous. And it's really clear that we need to be more descriptive and more understanding of what treatments we're going to give. We opted for a process of timely intubation of patients rather than having patients on many, many days of non-invasive respiratory support, in particular if they were not improving. When we look at our data compared to the data across the whole of the National Health Service, which is data for England, Northern Ireland and Wales, you see that across the complete numbers, the Guy's and St Thomas's Hospital admitted 2.5% of the overall patients admitted to critical care within the NHS. And indeed, we saw a survival, as I've said previously, which was 76% in the second wave. But overall, when we combined wave 1 and wave 2, was 74%, which was significantly greater than that across the NHS, which was 58%. Planning for the third wave is key. And when you look across Europe, or you look to see the Spanish flu, it's important to understand the key aspects to this. And the key point to take from this slide is that the third wave is never bigger than the second wave. And so we've done discrete event modeling to look at this, and using all those inputs that we have and using a team made of data analysts, data modelers and clinicians has allowed us to understand in terms of our predictions and our expectations for the third wave. And importantly, when we hit the triggers of 1.5% of the asymptomatic swabs being positive, when we hit 5 days, or we have 5 emergency admissions via the ED on a 5-day rolling average, or in the ICU an occupancy of 20 COVID patients, again on a 5-day rolling average, there's 31 days to the exponential and 56 days to the peak. This is planning time, and this is important planning time. So these data are for our GNA, or our general and acute beds, and this is for our critical care beds. Again, the same timelines agree that we've got 31 days and 56 days in order to plan. And as I've highlighted the key numbers from our own data, and I suggest others look at their own data, is 1.5% of asymptomatic swabs, 5 COVID patients admitted through ED on a 5-day rolling average, and 20 COVID patients in critical care on a 5-day rolling average. And it's really important that you have all 3 of those, because if community infection is not translating to emergency department admissions and not translating into ICU occupancy, then in fact you see that the actual chain has been broken, and the chain will have been broken by COVID. It's important to highlight by vaccine. It's important to highlight that when you hit the exponential And again, this is data shown in our hospital on 2 separate ways, is that 1 in 4 of those patients are going to critical care once you hit the exponential. Before that, the conversion to ICU is 1 in 8. So importantly, we need to highlight not just the acute COVID, because we've had a significant number of patients come through with other problems after they have had COVID. And I think we just need to think about long COVID and how we're going to use a holistic approach to patient care. So long COVID is expected to affect 5 to 10% of patients that we see with the condition. I think we need to be clear about the categories of COVID, because you have acute COVID, which I've just described, which will go to the acute medical beds or to the critical care. Then we've got post-acute COVID, which will continue on with symptoms of fatigue, fever, muscle aches and pains, insomnia for up to 12 weeks. And then following that, you'll have long COVID, where these symptoms of fatigue, insomnia, muscle aches and pains, breathlessness will persist after 3 months. But we need to separate that out from the soliloquy of COVID. And the soliloquy of COVID are those effects, those patients with pulmonary fibrosis, those patients with cardiac, renal, neurological or endocrine effects of COVID-19. And so thinking about these 4 groups will help you to best manage your patients. I've highlighted the symptoms, but I think it's really important to understand these again. And indeed, it is fatigue that's the overburdening symptom here. Yes, we'll see patients with muscle aches and weakness and pain and lethargy and impaired sleep quality with breathlessness. There's also the brain fog, short-term memory loss, and slower thinking. This is the COVID study that is recruiting these data from 1,000 patients recruited into the study. And you can see that, importantly, only 3 out of 10 patients who came through the hospital, that's both ICU and patients in acute medical beds, only 3 out of 10 are fully recovered by 5 months. And indeed, the patients divided into certain clusters based on mental and physical health. And so it's really important for us to understand. And interesting enough, the severity of the COVID-19 infection doesn't seem to predict those that are going to have long-term symptoms. So again, very key that we understand more and more about this disease. So our approach is we've set up a system where we will review patients, and the GPs will review the patients in the community. And they'll do a face-to-face consultation. And they will do a series of blood tests focused on fatigue, lethargy, to exclude any simple organic problems. The patients then are reviewed in a therapy-led, medically supported clinic. Most of these patients have therapy issues, physiotherapy, occupational therapy, psychological. And so we need to focus in terms of a holistic and need-based, person-centered approach to these patients. And my real key is don't become COVID blind, because indeed that is the problem both in acute and in long COVID. Don't over-medicalize the patients. Yes, patients with pulmonary fibrosis need specialty management, but many patients need to be reassured that they will improve over time, and that post-viral syndromes are not a new phenomena. And long COVID is a diagnosis of exclusion, but you have to balance that against the over-medicalization of patients. And so what I would say is acute care for COVID delivery is continuous and dynamic. You need to do surveillance, monitoring, and modeling. There needs to be a data-driven clinical care approach to aid your decision-making and understand the disease to apply the best treatments. Collegiate working is essential from the front door to the back door and beyond. And indeed, looking after the team's physical and mental well-being is a priority. Consider the categories of COVID. As I said, you have acute COVID. You have the soliloquy of COVID. You have post-acute COVID, and then long COVID. And the patients we're seeing with long COVID actually didn't have hospital admissions, and they had a milder disease, but they had symptoms that persisted for over 3 months. Thank you for listening.